Hello, good evening, my people. Namaskar. I hope you are having a great Sunday and that you had a good Sundays till now. We will be adding some more joy and excitement to your evening this time because we are going to talk about something really interesting, although about something that you were not familiar with before. I am your friend and a person living with multiple sclerosis, Anjali Vyas. My pronouns are she and her, and I'm wearing an orange top with black trousers. I have kept my hair loose and I'm wearing spectacles. So today we kickstart our campaign on disability awareness. So a little bit about the Multiple Sclerosis Society of India. So I'm a proud member of a wing called the National Youth Wing at the Multiple Sclerosis Society of India, which was established in the year 1985. Today, with our presence in over 8 states, today we are there in 9 states. And we have been creating awareness, advocating for the rights of persons with multiple sclerosis in Delhi, Mumbai, Pune, Chennai, Bangalore, Trivandrum, Hyderabad, Indore, and Kolkata. We have been holding several webinars and awareness sessions on multiple sclerosis ever since we started the National Youth Wing since a year. But this time we thought of actually doing something better and walk that extra mile to actually empower ourselves in terms of understanding other disabilities as well. Because we always keep on saying that you are not alone. So when we say you are not alone, it's not only restricted to persons with multiple sclerosis, but persons with disabilities at large. So today, as I said, that when we kickstart our disability awareness series to learn about various disabilities, also the ones which are not the part of the RPWD Act, we will be observing the IIH Awareness Month. IIH stands for Idiopathic Intracranial Hypertension. I know it's a tough term, right? It's a jargon. Ekdam confusion ho gaya na? So when we say hypertension, there are several terms that hit us. Is it really about stress? Is it really about tension? What is it really about? That is something which will be explained by my dear friend and also one of the speakers today at the session. So little bit of the background of our speakers today. We have got a very renowned neurosurgeon who has worked in NIMHANS, now is practicing in Andhra Pradesh, Dr. B. Vinod Kumar. He specializes in neurosurgery and he's the master of chirurgy. I hope I said that right, Dr. Kumar, because I had to actually check the pronunciation on the internet. So he's an MCH, which is master of chirurgy. And he has been also a doctor who has been treating our very own speaker, Kavya Poornima, who lives with IIH. Kavya Poornima is a young warrior of IIH and has been living with this condition since she was 18 years old. She is presently also a fellow at the National Center for Promotion of Employment for Disabled People. As a Javed-Abidi Fellow, she is working on accessible infrastructure for persons with visual impairment. So I bring to you two of our most amazing speakers, and I've known Kavya
It has got stuck.
Yeah, we lost you, Anjali.
I'm so sorry. I got out of the meeting for some reasons. I'm really sorry. Anyways, I was going to hand over the mic to you, Kavya, to speak about what IIH is. How has your journey been like with this invisible disability? Because most of us here who are living with MS also experience invisible symptoms. And we want to really understand what IIH is in right terms and not something that always internet tells us. So please enlighten us on what this condition is and share your experience. The floor is all yours. Thank you.
Thank you so much, Anjali, for the introduction. And also thank you, MSSI, for organizing this important session and starting the series of disability awareness. And also starting with IIH, because it's September and it's IIH Awareness Month. Global IIH Awareness Month. And firstly, I must thank Dr. Vinod Kumar for joining us today, because uh, I have been asking him since few days. Then, like, he is very much occupied with a lot of surgeries due to his profession, and he gets only a day time in the week to spend some time with his family. And I literally took his time, but then I really hope that it will enlighten everybody who's joining here, and he'll share a lot of inputs from his expertise in neurosurgery, and also talk about IH as how rare it is, and uh, all other things about it. Right. So to begin with, I was 21 when I I started experiencing headaches on a frequent basis, not regular basis, but frequent. Frequent, I must say, within a week of time, or maybe within 4 to 5 days, I used to experience headaches. So initially, I thought that these are something to do with my uneven sleep cycle, as in I was not having a proper sleep cycle those days due to the work I was doing. So I thought maybe because of that, I must correct my sleep cycles. Later part, suddenly I used to wake up from my sleep, and I used to feel very like very much heavy headed. Uh, a lot of throbbing headache used to happen, and I used to think that why is this happening? I am sleeping, but then it's not going away. And also I wear glasses, as who are watching now me, I'm wearing glasses. So I have on I mean, I also got a little blurred vision during those days. And I thought maybe it's been 1 year that I have to get my tests done with the ophthalmologist to check my number. Is there any difference? And there was a difference, and I changed it to the number, and then I got back to my work. And it was all nice. I mean, it was all going smooth. And later part, I slowly developed this constant headache. Uh, it was disturbing my routine, my sleep, my work, everything. And slowly, with this headache, uh, additionally, there was back pain. I used to feel pins and needles in my back. I couldn't sit for a while, and I had to lay back, and then even while laying back, I never used to feel comfortable. So that's when I thought there's something happening, and I'm becoming a little weak at that point. And from there, the headaches gone a bit high, and they were not going away with the help of any painkiller, pain management. But initially, when I got headaches, I thought like in our homes, everybody, like our elders, say that you have to sleep properly and you should apply oil to your hair so that it will go away. But I followed those, but it didn't help me out. And later I started coming to seek pain management, but then it didn't help me. And within a day or two, I became very weak that I couldn't get out of the bed, and I was admitted in the nearest clinic. And then uh, they tried putting me on IV pain management, and then the fluids were given to me because I was looking weak and I couldn't do anything on my own. So they thought, okay, let us put her on IV, and then maybe everything will be sorted. But it didn't. It became even more worse. And then I was also having this underlying condition called PCOS, which is polycystic ovarian syndrome. And surprisingly, PCOS Awareness Month is also September. So I just wanted to mention it here. And because of PCOS, I was taking medication. I was trying like different set of medication to manage my menstrual cycle. So while I was admitted in this clinic, I again got my bleeding back, like periods back. And then the focus shifted to the periods. And then I was admitted under a gynecologist, and then the treatment was started. But I was all this, whatever I'm explaining, this all happened within a span of 10 days. So After this, I was admitted under the gynecologist and I was asked to get an MRI done because my headaches were not going. It's been 1 week and the pain management was not at all helping me. And then the symptoms, other than the headache, were nausea and then vomiting. I couldn't eat anything because I was vomiting, even the water. So these things, when came up, the focus then was about the PCOS and bleeding. And when the medication started to control the bleeding, uh, I could feel little better because maybe I couldn't sleep the whole week because of the pain. Then later, the next day in the gynecologist clinic, my mother was trying to wake me up, and I was like, "Let me sleep because I didn't sleep for 1 week now. So let me sleep." And my mother was like, it's already morning and doctors will be coming to uh, for the rounds and they'll be talking to you, so you have to take medicine. And I was like, no, I feel it's dark, it's not morning now, let me sleep. And she was like, no, it's 9 a.m, you don't see light. Then I said, no, it's everything is dark, I don't see anything, it's black. And that's when we understood that I lost my vision completely. And my mother got panic and like she went to the doctor, and then doctors came, and then everything started there. That the gynecologist rushed me. I mean, just said that just you have to discharge from here and go back to a like get a better treatment done. I mean, this is something to do with neurology. It's not with the gynecology. So you have to move to a multi-specialty hospital. That's when we moved to the multi-specialty hospital. And then several tests were done and MRI, like several set of MRIs were done. And nobody were like clear what is happening, because the vision loss happened overnight. I could see light and colors and everything the previous day, and in the morning I woke up with no vision. So everything was confusing for the experts there. And several tests were done, and initially they even thought that it is MS. So they got this NMO done, and even couple of other tests, just thinking that this can be another neurological condition, but they didn't understand clearly that is it really something to do with like IIH or not. So they took like they took a day of uh, all the tests and everything, and then finally they came up with they just thought that the pressures are very high, maybe like after looking into the MRIs, and then they did this lumbar puncture. Lumbar puncture is a procedure uh, to drain the spinal fluid to understand the pressures, to measure the pressure. So I think my doctor can explain this even much better than me. So talking about this, like when the pressures got tested, they were too high. So too high, even this I will leave to my doctor, because he'll be explaining it in a better way. So they were the pressures were too high, and then why they were high, then they started investigating about the root cause, and then they took another day and came up with this term called idiopathic intracranial hypertension. So now talking about my situation there, I was admitted in the ICU. I was unconscious, I was not knowing what is happening with me. They were just dragging my stretcher to some other rooms. I was not able to see anything. I was just relying on the commands and surrounding noises, and I was just understanding that they are taking me somewhere, something is happening, and then they are giving some commands to me and I'm doing that. That's it. I was unable to move, I was unable to sit, nothing. So suddenly the doctors tell this term, and then my family was like, what is this? And I was in the ICU, and they were not sent on a regular timing. There used to be a timing to visit the patient in the ICU. That's when I used to just wait that my parents or family will come, or maybe the doctors will come, then I'll ask them what is happening with me, kind of. So that was the confusing state of mind. And later part, after the diagnosis, it took me almost 20 days to 30 days, I mean 1 month, to understand and pronounce my own condition. to literally know what is happening with me and the surgeries, what are the surgeries happening with me, because the surgery was a part of management for my condition. At that time, it was clueless what is happening. So later part, slowly I started recovering, I must say, and the whole year after this diagnosis and the surgeries, I was undergoing several set of revisions, because the earlier management which was done got failed without any reason, and then again I underwent another surgery, and then it was stable for few months, and then again it got disturbed, and then I underwent another surgery. So it was just like surgeries happening. So in this process, I with the help of my brother used to literally try everywhere, because the condition itself is new, the term is new, and the doctors doesn't know that much to share about this, and even on internet there is no data available for this condition. So my brother tried several ways, reached out to several experts in this field, and like tried to understand what exactly is happening with me. So whatever he used to get, whatever he used to understand, he used to share. And I was very curious to know what is happening inside my body, because I can't read, because at that point I acquired my visual disability, it's permanent disability, and I was unable to see anything. I couldn't use my phone or something to know what is happening. So I was completely relying on people, like even the doctors or my brother, whatever they say, okay, acha, this is what happening with me, kind of. So after that, after a year of these surgeries, the first surgery which I mentioned was a kind of experiment done to regain my vision back, because the vision loss happened due to my optic nerve damage. So now I have to talk about after the surgeries, like after the management, the continuous repetition, what is happening, why these managements always to be linked up with surgeries, why I have to undergo these many surgeries. So is this how life is going to be for me? Because I'm not doing any harm to my shunt which is placed inside, but why are they failing? So many several questions were coming to my mind, but only thing was ki, uh, these experiences made us learn even much better than the doctors or experts advices, or maybe the data provided on the internet. So that's when it helped us to guide even other people who are living with this condition. So now talking about IIH. So IIH can be just simplified into IIH, which is I means idiopathic, the other I is intracranial, and the like H stands for hypertension. So idiopathic itself means there is no specific cause. So the other I, which is intracranial, it actually means the pressure inside the skull, like in intracranial, the inside the skull part. And then hypertension is high pressure, the fluid pressure. So we have fluid surrounding our brain. I think I'm going into technicalities, so I think I can leave it to my doctor so that he can explain it much better. So yeah, Anjali, can you like just continue the flow, because if you can ask me anything, then I'll continue, because I'm just talking, and it
Sure,
won't
sure.
end anywhere.
I get that. Frankly speaking, it still gives me chills. I mean, every time I hear her story, guys, I mean, I need to be very honest with you all. I know her from my fellowship, and every time I hear her story, I mean, something or the other point hits me very bad. I mean, really, truly, I mean, I never really call many people inspiring, but she is one of them. So, Kavya, just tell me one thing. There are many terms you mentioned about shunt and pressure and several other medical terms, technical terms. Of course, I leave it to Dr. Kumar. But then tell me, what were you really? I mean, I'm sorry, I mentioned, I think in the introduction that you were 18 when this happened. I'm so sorry for that mistake. So you mentioned that you were 21 when you started experiencing the symptoms, right?
Yes.
What was your background then? Were you pursuing education? Were you doing anything particularly to maybe plan your career? Can you just also share those challenges that you have come across during that period?
Yes. So Yeah. So back then, when I was 21, I was doing my final year in graduation. And this happened when I was in Mumbai and I was doing my graduation. So during that, it was my final year. So I was very much occupied with the thesis work in the final year. And uh, like my schedule was something like today I'm in Karnataka, tomorrow I'll be in Tamil Nadu, and then coming back to Mumbai, and then going back to Andhra, and then like it was just like that. I was just traveling because of the field visits I had during my study. So I was managing everything quite well. I just wanted to mention this because I was pretty active at that point. And this, I must say, just a month before my loss of eyesight, this this was my schedule. So even the week before all the symptoms came up, during that time I was going to college and attending the classes and like engaging with all the assignments, and even like it like a very usual 21-year-old girl. So uh, right. So
So it was architecture, right? I'm sorry. I think the audience missed that point. So all my dear friends out here were listening to her. She was pursuing architecture, and she has done it. She recently graduated also from Mumbai in architecture. I mean, there was one statement made by her that really was a big motivation. And she said that in order to pursue my architecture, I don't need eyes or eyesight. I need vision, right? Which I think she has definitely. And that's the reason why she wants to work on the area of accessibility. Kavya, what were your challenges while pursuing that? I mean, after you experienced the vision loss, were there any barriers that you had to face, say at your college, or maybe in your family? I'm sure that must have also happened because we live in a society where there's lack of awareness. So, what were other challenges, if you may highlight them as well?
yes. So to talk about the challenges after visual impairment, I mean after loss of my eyesight, uh, initially it was more about me recovering from the surgeries and also other underlying conditions I developed, like I had, and also I developed during the course of these medication for the management of my condition. So I mentioned about PCOS. So I also developed osteoporosis. So it's about the lower bone density. So the doctors advised me not to move around, and I couldn't sit for even 1 to 2 minutes. So it was that phase where I had to take medication, which included daily injections for 3 years to get myself stable enough to sit for almost, like now I am able to sit for 2 to 3 hours now. So from 1 to 2 minutes uh, uh, till now, it's been a journey, I must say. So with these limitations I had, once I felt that I am little stable enough that I can think about my education, which was discontinued then uh, during my vision loss. I told my family that I wanted to I mean continue my studies back into architecture, and everybody was like, why? I mean, how was the first question? How you're going to do this, because you can't see and you have a lot of work to do with the visual content and you can't see, so it will be difficult for you. And the condition I had, I mean I'm having, initially the thought was also about too much stress will increase your pressures, and again it will lead to some or the other complications, because I was already dealing with many complications. So they were concerned about my health. And the other part was, why architecture? You can pursue any other course which can be easier for you, and also get a stable career in future. But uh, to get into architecture, it took me a lot, and I had to cross so many boundaries, and I had to convince many people, and it was a journey, like to choose architecture and then struggling there for 4.5 years. So it was just in the last year where I had 2 semesters. That was in the final year, which is 5th year. I had 9th and 10th semesters. So only 2 semesters were remaining. I could complete all the 8 semesters and there were no backlogs. And I was willing to do that. Then why not give it a try? So let us talk to the college first. What will they say? And then maybe take a decision. So when we approached college and college said, okay, first we want you here in Mumbai, and then we'll see whether you are able to, like you're fit to get back into architecture or not. So it was again a difficult time where we had to convince the college authority, and then the main task was given to us was to get the approval from the University of Mumbai to continue my studies. So that was another challenge. And then after that, after the wait for almost 5 months, 4 to 5 months, we received approval from the university, and then COVID happened and everything gone online. So for me, dealing with my condition, convincing them that I have this neurological condition, and also convincing them that with my visual impairment, I can still be able to do and get back into architecture. It was a task. I am still facing this even today, even after completion of my graduation. So yeah, so during COVID, I have to talk about that a little because everything gone digital, and for me, adapting to the change, understanding my condition, and uh, trying to overcome with, not overcome, I can say, trying to live with it, and maybe in a like learning things to do in a different way. Everything was everything was challenging because I couldn't travel because of the limitations I had. So I couldn't get the right help for rehabilitation at that point. So everything like using my phone or maybe trying to use a voice like talk back on my phone, because I use my phone with the help of a screen reader support and also other applications. So all these things was something totally new, and I didn't know about these things. And only thing I could do is giving a voice command and ask what are the available options for visually impaired to use a phone. I used to Google this and get some n number of videos, and then I used to just listen. Okay, this is how I have to do. And I used to take help with the family, and then start doing it on my own. So the starting rehab was done on like it was a DIY. So yeah. So later. That's how I found different ways to convey my ideas to my faculty in Mumbai through online. And that's how I completed my final year graduation with the help of my junior and then another friend that I had sync with, because in this field, it's a creative field. So you should have a proper understanding of design ideas that you have, and the same way they must also understand what you are trying to say. So it's still a challenge, I must say, but then I somehow tried implementing whatever I could and think whatever I mean whatever innovative idea or intervention I can think about at that point, and then completed my graduation. It took me like a lot of time, but then yes, last year I completed my graduation.
Well, many congratulations on that, Kavya. I'm sure the audience must be clapping. And we're really, really proud and happy to hear from you. Also, I forgot to mention, guys, I'm really sorry. If you have any questions, you can put it in the chat box. After Dr. Kumar is done speaking, we'll take up the Q&A, and Amit will be facilitating the entire session of question answer round. If you have questions to Kavya, you can ask them as well, and also to Dr. Kumar. So now, without further ado, because I'm sure that all of us are getting impatient to understand the medical aspect of IIH, so I give it to Amit to talk further about it. Thank you. Thank you so much.
Can I put some words here? As in, I intentionally wanted to like get you people learn from medical medical background expert. rather than me trying to use all the jargons and then trying you people to like confuse. So I didn't want to do that. That's the reason I intentionally didn't like talk about the technicalities. And also I didn't mention about my background because I wanted to be very clear about how an individual, a 21-year-old girl, is going through something and what is happening with her life, not attaching any backgrounds to that. So that's why I didn't talk about architecture then. Yeah. So take over, Amit.
Yeah, thank you so much, Kavya, for sharing that story. It's really brilliant. I mean, like on this platform for people to raise awareness about this condition. I'm pretty sure most of the people won't be knowing what IIH is. So I really appreciate that. Going ahead, we'll invite Dr. Vinod Kumar. He's a neurosurgeon, so he will be able to look enlighten us on the medical side of things. So, Mr. Vinod Kumar, doctor, please.
Yeah, am I audible?
Yes, doctor. Yes, doctor. Thank you.
Yeah. Good evening to all of you. I think I will take very less time because we are running out of time. I'll just give the awareness about IIH. So what it is? So it is already they described it is idiopathic intracranial hypertension. So the important part to a general public or to people is to diagnose themselves or to aware that they may have IIH, when they have to suspect that they may have IIH. So it is common that IIH is very common in female population. It is 8:1, okay, compared to male. So, and the confounding factor, it is one more thing, more common headache, migraine. Migraine also is more common in female. So that's where people will be neglected, that whenever if you go with someone, if you go with a headache to even one local practitioner or like rural practitioner, he will label it as a migraine. So in neurological terminology, there are two types of headache. What is called, one is primary headache, other one is secondary headache. So primary headache is without any demonstrable radiological or pathological imaging. So if you get an MRI, you won't find anything in that. Whereas secondary headache will be always secondary to some pathology in the brain. So the primary headache, there are two important headaches, there are three important headaches, but two are very common. One is tension headache, other one is migraine. So there is a set of classification and there is a criteria to fulfill migraine. So how to differentiate whether it is migraine or idiopathic intracranial hypertension? Migraine is very common, whereas idiopathic intracranial hypertension will happen. There are two, means per 1 lakh, there are two people can get affected, and it is most commonly seen in teenage group, so less than 45 years. So menstruating group, I can say, but it can happen in any age, and it can happen to men as well. So how will you differentiate when you have headache? Like I'm questioning myself, if I have headache, like if I am a woman, so whether it is a migraine, whether it is an idiopathic intracranial. So migraine will have unilateral most of the time, and it will be very severe. You cannot do any your daily activity, and the duration of the migraine will be like half an hour to 4 hours, and it will have some triggering factors. Some people will develop headache when they watch TV. Some people will develop headache when they eat chocolate. Some people will develop headache when they go to pub. The flashlight will trigger the headache, and it is always associated with photophobia and phonophobia, and there will be nauseating sensation. So when these type of symptoms, when you have, that is labeled or called as a migraine. So how it is differentiated from IIH? Migraine is pharmacologically treatable. So migraine won't have any pathology. It is like some, means whatever is demonstrable pathology or hypothesized pathology is like there is a dilatation of scalp vessels which will cause migraine. So beneath the forehead, beneath the scalp. Whereas within the brain there won't be any problem. Whereas IIH is a very serious problem where the pressure inside the brain will be rising. Okay, which causes there is a transmission of pressure along our optic nerve, which will serve vision. So that is, though it is called, seriously, it is used to be called benign intracranial hypertension, but it is no more benign. It is much dangerous than a cancer because you are functionally becoming independent because you are losing vision. There are 25% of people with IIH will tend to lose vision over the time. So what Kavya experienced is in a permanent IIH, where the duration of her vision loss and symptom onset was only 10 days. So whereas usually I have never seen like Kavya's type of case or history who lost vision within 10 days. But IIH patients will have headache. The headache may not respond to pharmacological like normal like analgesic like paracetamol, something headache what you take, Naxdom or whatever. So that headache will be like a step ladder. It will be increasing over the time. Okay. And one more thing, it is always associated with a nauseating sensation and sometimes the transient obscuration of vision. So you will have like floaters or transient vision loss. You will perceive that something is blurring. And there will be central blind spot when you see the object. And one more thing, the headache will be more common in the early morning when you get up from the headache. When you get up from the bed, you will experience the worst headache. So this is the basic idea that when you have a headache, which headache has to be taken seriously. So I'm telling you the primary headache and secondary headache. When you have to consider headache is a serious, because headache is, everybody will experience headache in their lifetime. Okay, this becomes a part of life. Even it is very routine to have headache due to because of this technological life or the upgradation we are seeing and the pollution we are having and all these things. So when headache associated with these are 9 symptoms into there, so that headache you have to take it as a serious, whether it could be an IH or secondary headache, which has to be evaluated, with imaging or any like lumbar puncture or anything. So the primary headache can be like taken a little light because you will be finding the stress factor, you will be finding sleepless nights, you will be finding a jet lag, you will be finding some travel before the night. So there will be identifiable stress which is causing headache. So most of the men will have tension headache, maybe due to wife. So this is the most common thing we will see. I'm just making jokes, but I think everybody is seriously listening. Okay, so second thing, when this IH, when you so what are all the symptoms IH patient can have? So headache which is not responding to pharmacological medication, and headache associated with vomiting, headache associated with transient vision loss, or there is a decrease in visual field. Means some people won't have the center vision. So you will be able to see the periphery of the vision, but you won't be able to see the center of the vision. And this is the most common because the IH will start with visual field defect. So if you are given 360-degree circle, so in the center part of the spot, center part of the vision, you may not able to see. This is the first thing that is called enlarged blind spot. When you go for an ophthalmological examination, they will tell you that you have field defect, that there is an enlarged blind spot. That means center of the vision is not clear, whereas peripheral part of the vision is clear. This is like quite opposite to some pituitary adenoma and like some other neurological tumor. So, and what you have to do. So the identification that you have a severe headache and which is not responding, and it is stepwise, it is increasing, the severity is increasing, and the character of headache, some sobbing headache to constricting type, some change in the headache, whereas a teenage person who is more commonly seen in female, reproductive age group, when you have the only identifiable pathological association factor, which was till now as identified as a risk factor, is obesity. So obesity and then anemia. So these are the two things which is attributing to idiopathic intracranial hypertension. It may not be the etiological factor in every case, whereas in Kavya she was not even obese, she was like very thin girl and like normal. But usually IIH is commonly seen in obese women because the pressure changes, intra-abdominal pressure changes, which will this like a vicious cycle, which in turn will increase the intracranial pressure. So the treatment part. So there are two types of treatment. One is lifestyle modification is one thing, which your weight loss will decrease the intracranial pressure, and there is a pharmacological medication, and then second thing is surgical management. So when you don't have any visual acuity or vision loss, so only the headache will be there in IIH. So in that aspect, so if you decrease the water production, which is called CSF in the brain, so that will give you maybe complete relief or partial relief in some patients from headache. So, but how long it has to be taken is like initially we have to evaluate the every week whether the pressure is decreasing or not, which will be identifiable through an ophthalmological examination, where the eye examination fundus shows there is a pressure that is called papilledema. Okay, so that will be shown. If patient is having papilledema and the headache is not responding, then straight away there is a surgical option. There are so many three options for nowadays we are practicing three options. One is optic nerve sheath fenestration, and the other one is shunt, whether it is can be like picoperitoneal, like you can do from backside to abdomen, like lumboperitoneal, you can say. And third is the ventriculoperitoneal, from head to abdomen. And the third modality of choice is shunting, where one of the blood vessel, like we'll call it as sinus, transverse sinus, where it is narrow, which is causing raised ICP. So there we will dilate that venous sinus. That is called transverse sinus stenting. That is different from shunting. So these are the options for IIH. And IIH, how severe it is, vision loss. So when you identify in the early stages, like every patient may not have fulminant IIH. There are they may be having experiencing headache. Hello, any issues?
Yes, doctor, please go ahead.
Yeah. So if there will be a long duration, means I have one more patient in my residency, because Kavya was joining, she was treated in NIMHANS when I was junior doctor there. So I have seen one more BTech girl who has presented with headache, vomiting, and severe headache. So actually, the confounding factor, she has been seen in 3-4 hospitals where they couldn't able to identify the factor which is causing headache. So what they were thought is like encephalitis, that is like the infection of the brain. That's what they thought. So many neurologists have seen. Finally, they are referred to neurosurgery. And unfortunately, what has happened, the patient had some tumor in the brain. So ideally, if there is a tumor, that should not be called as an IIH. Okay, but I don't know, but personally, I felt that was an IIH because the tumor itself was 1 centimeter tumor. So, and which is not causing any displacement of the brain parenchyma. So that time, however, one of my senior doctor told that it could be due to tumor, so we'll remove the tumor. So she has undergone surgery and craniotomy, like we opened brain and then tumor was removed. She had relief of the headache and she was fine. And then after 3 months, she came with vision loss. So it was quite surprising that that was an IIH. So I asked my professor that time, sir, can we do LP? Because I feel though it is a small tumor which is not causing this much headache, it could be IIH. But he didn't agree, because when there is a neurological imaging showing some tumor, it should not be called an IIH. But I still felt that he is having severe intracranial pressure. So after 3 months, he came with vision loss, but not like complete vision loss. And then when we examined, and ophthalmological examination showed there is a one eye optic atrophy and there was little bit cerebral vision was there. So she undergone shunt, but there is partial improvement, but still we couldn't able to get back her normal life. So this is the picture where this is the type of presentation IIH people will have. So it is basically the awareness, not the treatment, because by the time you land in a hospital, you will be, most of the patients will be in irreversible state.
Dr. Vinod, I'll just interrupt here. because we have a lot of questions which are coming out. We have shared a lot of information here, and people are very much interested to know more. So I'm getting a lot of questions in the comment box also.
Yeah, I'll end this here, so I'll go to questions.
Sorry. Okay.
I will end this my topic here. I'll go with questions, and one sentence I have to say. Hypertension and idiopathic intracranial hypertension both are not same. So the blood pressure is due to the vasculature, like blood vessels, which are getting narrowed due to age. That is called atherosclerosis. So there is a fat accumulation in the vessels, which will hamper the diameter of the vessel. When the diameter of the vessel is this much, at the younger age, when diameter will shrink this much, so there is a resistance to blood flow. So which is causing rise in blood pressure. That is called hypertension, which is it is like outside the brain. Whereas idiopathic intracranial hypertension is within the brain. It is nothing to do with normal hypertension.
Okay, doctor.
Yeah, now we can go ahead.
Yeah, Ms. Jyoti is asking the question that IIH is really an invisible disability. So do we know the reason and cure for it?
Reason means which is causing occurrence of IIH, or which
what
is
causes this condition? I mean,
no,
that's what I is asking.
That is why it is labeled as idiopathic intracranial hypertension, where you won't find identifiable risk factor, but only thing which is still now identified is obesity. But it is not same in in every case, because even non-obese can get IIH.
Okay, and can you just tell us how many cases you have come across like this? I think it is pretty rare.
Yeah, it is. That's what I told you. In 1 lakh population, you will see 2 patients.
Okay, that's very, very rare. One more thing. The thing is, how this question is for Kavya. How do you manage this particular condition in your life? Kavya Poornima?
Yeah. So, yeah, I told you, like I told earlier about the surgical intervention which is done on me. So the first surgery I underwent was optic nerve sheath fenestration, which doctor have already, like he have already mentioned about it. So this particular surgery was to decompress, like my nerves got compressed due to the pressure inside my brain, and my eyesight was lost. So like my vision loss happened due to that. So to decompress the nerves and just as a try that again I'll regain my vision back. That was the surgery which was done, but it didn't help me much because in my case everything happened very rapidly, which again doctor told about fulminant IIH. So IIH is itself a very rare condition. In that fulminant IIH is something that has no data available nowhere. So yeah, now coming back to that, so for my vision we tried that like surgical intervention which didn't help. So after that, after optic nerve sheath fenestration, the shunt was introduced. Even about shunt doctor have mentioned, so I would like to simplify that because he said lumboperitoneal shunt or thecoperitoneal shunt, which is spinal shunt. So initial stage, spinal shunt was introduced, and then it didn't help me, and it got failed without any reason. And I underwent 2 other replacement surgeries, spinal surgeries, to manage the condition. Because if the shunt is not there, the drain of my fluid is not happening, and then again I get my headaches back, and it will again disturb everything. Like relapse will happen. So to avoid that and to manage with the condition, because there is no cure for this condition, it's only treatment management. So in my case, it's extremely chronic. So I manage my whole IIH with surgical intervention, and I am associated with neurosurgeons. So I told about spinal shunts. So spinal shunts didn't help me initially, like after 3 revisions. Finally, I am right now surviving with a brain shunt. So it's the shunt implant is placed in my brain. So with that, I'm surviving. And the management will be with the ophthalmology assessment every 3 months, that just to check whether there is any pressure accumulating in my eyes. That means in the nerves. If there is anything, any minor change in that, they will again refer me to the neurological like neuro department, and then from there, again, any other interventions or any other tests are done. I mean, if they suggest me. So apart from that,
Sorry, Kavya, I'm interrupting here, Kavya. When you say shunt, what exactly it is? Is it like a thin pipe? So because most of our audience will not really understand the meaning of the term shunt.
I think
So is there a
I
pipe
will
fix or a
explain
tube?
I think Dr. Vinod can explain it much better.
No, it is because you are going deeper neurosurgery. You are trying to get neurosurgery degree without any exam. Okay. I don't because she is expert in IIH. She knows much better than me. She's a Wikipedia of IIH. So she can talk per day. Okay. But there are two types of shunt. Okay. Which is from backside to abdomen, because it is like a mechanical device which will drain the fluid which is called CSF into peritoneal cavity. So you can do it in two ways. One is from back, means lower back to abdomen. Otherwise, from brain directly to abdomen. So lower back to abdomen, there are two types of shunt. It is called programmable, not programmable. So there are programmable shunt, means you can set a pressure. At that pressure only, the device starts will working. So it will drain the fluid. So which was required for her. So in other two options, which she has undergone second surgery and third one revision, she has undergone non-programmable shunt. So that's why there was a failure, and shunt itself is a mechanical device which can get occluded at any point of time. So that's why it may require revision of the shunt. Means second, you can do one more. You have to revise the shunt. You have to
Can
place a new shunt.
Can you talk about the material of the shunt, because it will be
that
more
is a plastic
easier
device.
for them?
That is
yes.
Like just plastic device. Nothing else will be there. But when there is a programmable shunt, you will have like a wheel. So where there will be pressure changing. So it's like same. I was telling about her how it is shunt when you are traveling in a flight. So you will be you will be asked to chew a chewing gum or chocolate to equalize the pressure within the brain and outside because of altitude changes. So same thing will happen to her also. Whenever there is a weather changes, the intracranial pressure, outside pressure will change. So the difference between intracranial pressure and outside pressure changes, then she will get a headache because we will set a pressure at that pressure only, it will drain. When there is an environmental change, the difference will get more. So that's why programmable shunt will work better than a non-programmable shunt.
Thank you. Thank you so much, Doctor. We have our National Secretary of MSSI, Sandeep Chitnis here. Mr. Sandeep?
I think there is one more question.
Yeah, please.
I would like to answer. So there are two questions, same answer. When there is an optic atrophy, okay, there is no, I think I should not say in medical terminology there is no chances, but there are less chances to get back vision. Okay, so when there is a papillary edema, at this stage, if you intervene with a shunt or a pharmacological medication, there is a high likely to get a vision back. Okay, so IIH is curable according to patient and the early stage of IIH. When you go into irreversible stage, it is unlikely to get back the vision normal.
Thank you, Doctor. Thank you for sharing this. I think I'll just hand over to Arun here. Yeah, thank you so much once again for sharing all this journey. Kavya and doctors for sparing the time and sharing the knowledge with us. Okay. Please, Arun.
Sure. Mr. Sandeep, would you like to put in your thoughts about this?
Yes. Hi.
Yeah.
Hi, everybody. Actually, I've been out. That's why I avoided on the call. And the reception was also not good. So it was really, I would say, enlightening as well as revealing to know about IIH and the way in which Kavya has suffered for all this. So, and I really thank her for sharing her experience. And it is quite inspiring that in spite of all these challenges, she could overcome that and become architect. So I really salute that grit. And I also really thank Anjali to conduct it in a nice way, and doctor also to mention all the nitty-gritties about medical issues about IIH. Now coming back to this is one thing which I will like to discuss with all of you is uh, all these different neurological disorders which are although unfortunately not uh, mentioned as part of 21 disabilities, and also the one which are mentioned as part of 21 disabilities like Parkinson and others, and similarly blood disorder like sickle cells, etc. So which are already classified as a part of 21 disabilities. It is why it will be good for Multiple Sclerosis Society of India to collaborate with them in a way that we can effectively do a lot of advocacy. Now, advocacy can be where we can really collaborate. We can collaborate with neurological disorders as well as blood disorders in three ways on a broad term. One is pertaining to employment opportunities. In case of RPWD Act, there is a concept called reasonable accommodation. So we will be looking at advocating various measures to provide reasonable accommodation to these people who are suffering from either of this neurological disorder or blood disorder, by which it will be possible for them to gainfully continue in their present employment. That is one thing. Another one is looking at on a broader perspective about all the benefits which are being given to under Disability Act, which are unfortunately not given to all the people suffering from various disabilities in a uniform way. What I mean to say is, even multiple sclerosis is not covered under some of the benefits which are being given, while like sometimes railway concessions and all, and some of the visible disabilities, they are given other concessions. So we should be looking at getting all the concessions which are uh, legally due to these people, whether they are suffering from neurological disorder of any of type or blood disorders. They should be getting this benefit. And there must be uniformity about classification also for various benefits. So of course, that will be, we can discuss at length. And there is one more broad point is regarding advocacy for reduction of various drugs price. In case of multiple sclerosis, DMDs are very crucial. In case of other diseases, also there will be specified medicines on which higher duty might have been levied, which we need to look at reduction as much as possible. So we need to represent it to the government authorities. So for all this, combined effort for advocacy is warranted. And this is one thing which we are looking at on a long-term basis, whether it is for neurological disorder, blood disorder, and even rare diseases, we can go for it. That's all I wanted to say. And over to you, Arun.
Yes. Thank you so much, Sandeep, for this enlightening speech also. At the onset, I would like to thank Dr. Vinod and Kavya for this really enlightening talk that you gave. I have just one sentence. The moment you started talking about your about the disorder, from the time I was diagnosed, the only thing that I could think about is, oh, ऐसा भी होता है. I swear it. Today, when I look at you, ऐसा भी होता है. That's just a statement that I need to make. Thank you so much, Kavya. Thank you so much, Vinod. And I should also thank Vinod for that, Dr. Vinod, for the enlightening talk about what IIH is all about, and what are the symptoms and what could be the cure for it, which can help. And I would like to thank Anjali, Sanket, Amit for this entire session that we were able to put together. Thank you so much, all of you. And thank you so much again, Kavya. Thank you so much, Vinod. Thank you.
Thank you, audience. Thank you, audience, for bearing with us.
Thank you.
Yes.
Thank you.
Thank you.